is limited, and then you reach to a diagnosis. As soon as you need some investigations, and then you reach to a diagnosis, and finally you deliver a treatment. Please remember, the thyroid disease, they need very critical, diagnosis. Out of your negligence, out of your negligence or ignorance, you can you can misdiagnose. You will be misdiagnosing the patient, and in the same way, you will be developing a wrong strategy for as far as the treatment is concerned. So one has to be very very careful. Please remember, the spectrum of disease in case of thyroid is only four. You, as soon as the patient comes to you, your first thing that you would like to take upon the history if the patient is hyperfunctioning or patient is hypofunctioning. Please remember, the symptoms of the hyperfunctioning are very, very vague. They are very vague. You will not be able to pick up on the history when you're taking the patient, and in case of a hypothyroid. It is on the process of exclusion that the patient is not having a hypothyroidism, and then the patient you diagnose the patient. If the patient is not having the symptoms of hyperthyroidism, it means the patient has got a problem of hypothyroid. So the major symptom on in case of hyperthyroidism: mental excitability, tachycardia, tachypnea, losing the weight, polyphagia, mental disturbance, abnormal nervous excitability. Now, these are the major symptoms. If these symptoms are present, it means the patient has got a hyperthyroidism. If these patients are not present, and it means that the patient is having the hypothyroidism. So these subclinical issues are usually encountered in case of the hypothyroidism. The first thing is that you pick up whether the patient has got a hyperthyroidism or hypothyroidism. Number one is a physiological issue. Number two, you discover the inflammatory issue, inflammation of the thyroid gland, and particularly autoimmune disorders. And very much well known in case of hypothyroidism is the Hashimoto's problem, Hashimoto's disease, and in case of hyperthyroidism, it is a grave disease. So these autoimmune, and then in addition to other, inflammation of the thyroid gland in the form of acute thyroiditis, renal thyroiditis, or recurrent thyroiditis. There are so many, thyroiditis that you encounter. But this is not that much common. Number three are the malignancies. Please remember, malignancies are very much important. These malignancies, as I said earlier on, when you encounter the malignancies, these malignancies are to be always discussed with the nuclear physician. They are, but fortunately, the malignancies of the thyroid gland they are very indolent. They give you a lot of time, except in case of an anaplastic malignancy. So majority of the malignancy are indolent tumor in the form of papillary carcinoma, and the other well differentiated, that is around about 70 to 75%. 5 to 10% are the follicular malignancies, and then begins the medullary carcinoma with a 5%, the lymphoma, and then the the anaplastic malignancy. So anaplastic malignancy usually comes under the heading of the well-differentiated malignancy, because that is the phenomenon of tumor de-differentiation, where the malignancy was well-differentiated, and because of the long-standing disease, it has de-differentiated into an anaplastic condition. So this is a very simple spectrum of the disease. So whenever the patient comes to you, you take a history, keeping in you this spectrum of the disease. This spectrum of the disease. If the patient is having hyper symptom, if the patient is having hypo symptom, if none of them are present, then the third category, which will fall into the category, will be a malignancy. So all malignant features, the patient, the well-differentiated malignancies, they are usually less aggressive, indolent, they are asymptomatic. Now you do a clinical examination. When you do a clinical examination, you do, as the swelling is, there is no specific except that you do an indirect laryngoscopy. It is still doubtful. Okay, why you do an indirect laryngoscopy? I don't know. Okay, in majority of the cases, in 99% of the cases, we find the vocal cord, the functioning normally. But I think some reason is some people say on the documentation. Anyhow, I would like all of you, if, for example, the patient is having the hoarseness, change in the voice. Now, these are the cases who warrants the examination of the larynx. Otherwise, the patient is having a normal voice. The asymptomatic vocal cord process is still, I have yet to see a patient. Then these are the, as you know, the swelling of the neck. You know it, how to see the swelling of the neck. Deglutition, you see a deglutition. And the why it moves on swelling? Anybody? आप बताएं, आप लोग पीछे वाले बताएं. Why the thyroid swelling moves on swelling? हम्म आप बता दे. अच्छा ठीक है. It includes the thickenings are known as the Barry's ligament. They are attached to the laryngotracheal framework. So in the second stage of swelling, in the third stage of swelling, the larynx moves up, and in this way the thyroid gland also moves up. So any swelling, it is not only specific to the thyroid gland. Any swelling which is attached to these framework, it moves on swelling. So you have to differentiate. The greatest thing about as far as the investigations are concerned, please ignore writing the thyroid profile. Now, this is a misnomer, this is a misconception. Ignore. You have to specifically target. If the patient is having, if the patient is not having a symptom of hyperthyroidism or the hypothyroidism, so these investigations like thyroid function tests, yeah, they are not that much relevant. They may be relevant as far as the NEC is concerned, when subsequently you will be opting for surgical intervention. Otherwise, they are not that much relevant. So the simplest way of advising, if the patient is not having, the simplest way of advising is single investigation, and that is the TSH is sufficient. TSH is super sensitive test. It is sufficient to look into whether the patient is having a hyper or hypo. The second investigation that is usually advised is an ultrasound. Previously, ultrasound was advised only. Still now, previously it was advised only to see the size and the cystic and solid component. Nowadays, with the latest generations, ultrasound, you can discuss, and please ask your ultrasoundologist always describe the ultrasonic features. Ultrasonic feature according to thyroid or ultrasound classifications. So always discuss with them. Always discuss with them and give very much concern to the features of ultrasound. And then please remember, these investigations alone are not sufficient. You have to correlate your historical background, history background, your finding on clinical examination, and then you see the ultrasonic features. Ultrasonic features alone are not sufficient. So whenever you find the abnormal thing, you always subject the patient to the fine needle aspiration cytology. There are only two types of surgery, or you can say there are three types of surgery. Only left on thyroid surgery. Nothing less than lobectomy. Lobectomy means removal of the lobe, no residual tissue, intentionally at the bed. That means it warrants the exposure of all the important nerves, the parathyroid gland. So it is a mandatory for a thyroid surgeon to identify these structures. This was the previous dictum. The things goes on, metamorphosis, as I said. The metamorphosis, previously it was a thought dictum. You do not seek the nerve, you may damage it. Nowadays, you want to save it, you always identify it. So identify full identification, not partial identification, whereby you only look into the nerve, a portion away, then you become a happy person. Maybe possible distally or proximally, usually proximally, you can damage the nerve. Despite that, you have seen the nerve lower down. So these are the important aspects where you. The second surgery is a total thyroidectomy. There should the surgery like subtotal thyroidectomy is, or a near total thyroidectomy is not advised nowadays. It is only in some of the very specific cases where you can opt the near total thyroidectomy. Otherwise, total thyroidectomy, lobectomy. And the third one is you extend your surgery with the neck dissection. So usually in case of the malignancy. So this is complete. Now, uh, there comes the role of radioactive iodine. That is the role of the nuclear physician. Now, the patient has to be discussed with the nuclear physician. If it turns out to be a malignant one, usually the well differentiated. The well differentiated papillary carcinoma, the uh, follicular malignancy, and poorly differentiated. Please always remember the poorly differentiated are again the iodine avid tumors. So that you have to discuss. And majority of the cases, for example, the malignancy is of stage 1 and stage 2. Even in case of stage 3, where there is the minimal invasion of the capsule of the or the vessel, in those cases, you have to limit yourself to a surgery and then there is watchful follow-up. As far as the radioactive iodine is concerned, in those cases, there is a gross invasion, or there was involvement of the lymph nodes. So in those cases, that warrants the application of radioactive iodine 131 ablation therapy. फाइनली एक जो पेशेंट है जो कि आपके साथ प्रेजेंट करता है और वो है नॉन गोइटरस पोजीशन. नॉन गोइटरस पोजीशन ये है कि नॉन गोइटरस हाइपोथायराइडिज्म, नॉन गोइटरस hyperthyroidism, non-goitrous. Patient is not having solution. Now, these are the cases. These are the cases initially go to the physician because it is not an apparent swelling, so they do not go to a surgeon. The symptoms are vague, they initially go to the surgeon. And particularly in the cases of the hyperthyroidism, when they are non-goitrous, they initially go to the psychiatrist because there is an excessive nervous excitability. Their actions are very abrupt and abnormal. So these are the cases whom you must discuss with the endocrinologist. It is not a surgical case. It is not a surgical case. These are the cases who are usually dealt by the in a non-surgical way. In a non-surgical way, in case of an intractable hyperthyroidism, where you're going where you're giving the thianomides, that is an anti-thyroid drugs. In those, the best way of treating with the use of thianomides are the endocrinologists. They know their tricks. It is their job. So give this patient to them, let them treat. In some cases, this happens. This happens in case of the hyperthyroidism. The patients are not treated by the antithyroids. So these are the patients, they are being sent to nuclear physician for the iodine 131 ablation therapy. So these
being treated by the nuclear physician. If the patient is having hyperthyroid, is there any role?
yes, there is a definite role. There is in case of the refractory case, ये वो थोड़ी डिटेल में से in case of refractory cases, medically, the endocrinologists fail to control, then the patients are sent to non-goitrous. Please always remember, if it is a goitrous one, it is a purely a surgical case. Hyperthyroidism. You control, you optimize the levels, and then subject to a total thyroidectomy. But if there is a non-goitrous one, if the patient is not being treated by even a nuclear physician, then the last, result is surgical. The first. Lastly, the Graves disease. The Graves, जो आपका एक क्वेश्चन भी होगा उसको डिस्कस भी हम करेंगे. Graves disease is a purely a surgical case. Some people are trying iodine 131 ablation therapy because they are usually they present with eyes. So they are non-goitrous patient. For example, you are treating with a nuclear physician using the iodine 131. It interplaces the it induces a severe inflammatory response, and then it will cause the damage to the optic nerve. So this is why these initially in inhibition, right from the outset, they are being treated by surgical intervention. कुछ सवाल है उसके बाद शुरू करते हैं.
Sir, you told us about the role of ultrasound in thyroid. So, but you did not mention the role of ultrasound in detecting the lymph nodes with thyroid.
when you are doing the ultrasound, when you are doing an ultrasound, so the ultrasound will cover the neck.
Yeah.
Will cover the neck.
It has a role in detecting the lymph nodes, especially in malignant cases.
बिल्कुल. अच्छा, दूसरी बात ये कि देखें, मैं आपको बताऊं एक बात कि since the well differentiated malignancy, though they have got a very very slowly growing disease. They are indolent, slowly growing disease. They do not give rise to much constitution symptom. It doesn't threaten the life, even in the presence of the neck nodes. But you have to be very, very careful. किसी ने point out किया, बिल्कुल सही है. If the neck nodes are there,
Because the first investigation would be ultrasound.
Thyroid scan has lost its importance. Please do not write the thyroid profile. When you write the profile, it was previously understood that profile means a scan with thyroid function test. Nowadays, please, whenever you have to advise the thyroid function test, this is the thyroid scan. The only indication preoperatively is the functioning nodule. Whenever you find that TSH is low, TSH is low, it means the patient is maybe having an hyperthyroidism. So maybe possible the patient has got the subclinical hyperthyroidism. So in those cases, what you do, you advise the scan. Why you advise a scan? Because you want to find the functioning nodule. Because if you find the functioning nodule, it means that warrants only surgery. You have to do a surgery, remove that functioning nodule. The remaining resting thyroid gland will wake up by itself. So you will be saving the patient, rendering that permanent hypothyroid. So in those cases, the scan is important. Post-operatively, yes, they are important in order to look into the residual tissues, particularly in case of the malignancy. So this is important. As far as the CT scan is concerned, previously it was very it was not वो तो ज़ाहिर है अल्ट्रासाउंड वाले
Ultrasound guided.
जो इनका डिसीजन होता है वो खुद ही देख लेते हैं कि कौन सा जो है
Most suspicious.
कैल्सिफिकेशंस हैं, हाइपोइकोइक है, उसके मार्जिन कैसे हैं, वो सब देख लेते हैं. और एक बात और बताऊं मैं आपको कि ये आप एडवाइस करें उसको. कभी कभार ये होता है क्योंकि हमारी नीड है ना, वो उनको बताएं. वो नीड क्या है हमारी, हमें डायग्नोसिस चाहिए भाई.
Most suspicious.
हमें डायग्नोसिस चाहिए. डायग्नोसिस वो क्या करेगा, एक ही नोट में डाल के नीडल और स्प्रेड करके, या वो ट्रूकर एक में किया और वापस करके आ गए. अब लिम्फोमा एक पेशेंट था हमारे यहाँ, नॉन हॉजकिन लिम्फोमा थायराइड का. हमने उसको जो एडवाइस किया तो ही डिडंट नो कि इसको 5 जगह से लेनी है. At 5 places you have to take a true-cut biopsy, because and then it turned out to be a lymphoma, and the patient was saved from surgery and a simple way of treatment. So this is how basically there is a multinodal goiter. Please ask him to take a biopsy, to take a from the multiple places, particularly the larger one.